Hello everyone, welcome back to our channel. In today's lecture, we will discuss an important emergency medicine topic, NOAC antidotes, also known as antidotes for novel or non-vitamin K oral anticoagulants. NOACs, including Dabigatran and factor XA inhibitors such as apixaban, rivaroxaban, and edoxaban, are widely used to prevent stroke and treat various venous thromboembolism. Although these drugs are effective and safer than warfarin in many situations, they can occasionally cause life threatening bleeding or require urgent reversal before emergency surgery. Fortunately, specific reversal agents are now available. Idarucizumab is the antidote for dabigatran, while Andexanet Alfa reverses the effect of factor XA inhibitors. When these specific antidotes are unavailable, 4 factor prothrombin complex concentrate or 4-FPCC may be used as a non specific reversal option. In this lecture, we will learn when these antidotes are indicated, how they work, their dosing, clinical applications, and current guideline recommendations. So, let's begin by understanding the emergency management of NOACs associated bleeding. Let's begin with a real life emergency case. This is Mr. Ramesh Kumar, a 70-year-old man with a history of atrial fibrillation and CKD stage 3 chronic kidney disease. He has been taking Dabigatran 150 mg twice daily for stroke prevention, and his last dose was taken just 4 hours before the presentation. He arrives at the emergency department with a sudden severe headache and left-sided weakness that started 45 minutes ago. His blood pressure is 190 over 110 mmHg and his NIH stroke scale score is 14, indicating a severe neurological deficit. A non-contrast CT scan of head confirms a right basal ganglia intracerebral hemorrhage, which is a life-threatening medical emergency. His laboratory results are also significant. The APTT and diluted thrombin time are markedly prolonged, confirming the anticoagulant effect of dabigatran, while the PDINR remains normal, which can be misleading in patients taking dabigatran. The key takeaway in this patient requires immediate reversal of the dabigatran with its specific antidote, idarucizumab, to control bleeding and improve the clinical outcomes. Now, it's time to make an emergency clinical decision. Our patient has a dabigatran associated intracerebral hemorrhage. Confirmed on CT scan, his blood pressure is 190 over 110 mmHg and his neurological condition is rapidly deteriorating. What should be the first immediate step? Option A. Urgent hemodialysis can remove the dabigatran from the blood, but is not the fastest option in life-threatening emergency. Option C. 4-factor prothrombin complex concentrate or 4-FPCC may be considered when a specific antidote is unavailable, but if it is not the first-line treatment for dabigatran, reversal. The correct option is D. Idarucizumab 5 grams IV. Idarucizumab is a humanized monoclonal antibody fragment that binds specifically to dabigatran and rapidly neutralizes its anticoagulant effect, often within minutes. So, in any patient with life-threatening bleeding while taking dabigatran, the first-line treatment is immediate administration of idarucizumab 5 grams IV. Before using NOAC antidotes, it is also important to avoid some common but potentially fatal mistakes. Error 1 is relying on PT or INR to assess the anticoagulant effect of dabigatran. A normal INR does not rule out significant anticoagulation. Instead, tests like APTT or diluted thrombin time provide more useful information. Error 2 is using fresh frozen plasma or FFP as the primary reversal strategy. It does not effectively reverse the NOACs and may increase the risk of fluid overload, especially in critically ill patients. Error 3 is assuming that hemodialysis works for all NOACs, while dabigatran can be removed by dialysis. Factor S XA inhibitors such as rivaroxaban, apixaban, edoxaban are highly protein bound and cannot be effectively removed by this method. Finally, error 4 is using the wrong antidote. Idarucizumab is specific only for dabigatran, while Andexanet Alfa is used only for factor XA inhibitors. So, always identify the specific NOAC before selecting the appropriate reversal strategy. Choosing the correct antidote can be life saving. Now, let's summarize the 5-step algorithm for NOAC reversal in the emergency practice. Step 1 is to identify the NOAC the patient is taking along with the last dose, timing, and the renal function because these factors influence the drug activity and the choice of the treatment. Step 2 is to confirm the anticoagulation activity using the appropriate laboratory test. For dabigatran, the tests such as diluted thrombin time or adherent clotting time are preferred, while calibrated anti-factor XA assays are used for factor XA inhibitors. Step 3 is to administer the specific antidote using Idarucizumab for Dabigatran and Andexanet Alfa for factor XA inhibitors. Step 4 involves supportive management including strict blood pressure control, airway stabilization, and treatment of the underlying bleeding source. Finally, step 5 is to closely monitor the patient and decide the appropriate time to restart the anticoagulation once the bleeding risk has resolved. So, the golden rule is first identify the NOAC, then choose the correct antidote. In life threatening bleeding, every minute counts and early reversal can be life saving. Selecting the correct laboratory test is essential when managing the patients on NOAC therapy because different anticoagulants require different assays. For dabigatran, a direct thrombin inhibitor, the APTT, may be prolonged, but it is not reliable for measuring the exact drug level, and PTINR is generally insensitive. The preferred test is diluted thrombin time or DTT or the adherent clotting time ECT, which are considered the gold standard. After successful reversal with Idarucizumab, the DTT should return to normal. For rivaroxaban and apexaban, which are factor XA inhibitors, routine coagulation tests such as PT and APTT are unreliable. Instead, a drug-specific calibrated anti-factor assay test is preferred. After reversal, the anti-XA level should decrease towards zero, indicating effective anticoagulant reversal. Similarly, for edoxaban, routine coagulation tests are also insensitive, and a calibrated anti-XA test is recommended, although it may only be available in specialized laboratories. Never rely solely on PT or INR for the patients taking NOACs. Always match the laboratory assay to the specific anticoagulant to ensure accurate diagnosis and effective reversal. Now, let's understand how two major NOAC antidotes work at the molecular level. Think of idarucizumab as a molecular trap. It is a humanized monoclonal antibody fragment that binds specifically to dabigatran with an affinity much higher than the thrombin. Once it binds, the dabigatran is rapidly neutralized through a one-to-one irreversible interaction, leading to reversal of anticoagulation within about 4 minutes. On the other hand, Andexanet Alfa works as a decoy or a molecular sink. It is a modified factor XA protein that attracts and the factor XA inhibitors, such as apexaban and rivaroxaban, preventing them from inhibiting the body's natural factor XA. This restores the normal clot formation. However, because Andexanet alpha is a has a relatively short half-life, so the anticoagulant activity may return after some time, so the patients require close monitoring for rebound anticoagulation and thrombotic events. The key takeaway is simple. Idarucizumab traps the dabigatran, while Andexanet alpha acts as a decoy sink for factor X inhibitors. Choosing the correct antidote depends entirely on identifying the specific NOAC involved. Now, let's compare the two specific NOACs antidotes side by side. On the left is Idarucizumab, also known as the brand name by Praxbind. It is a specific only for dabigatran and is given as 5-gram IV dose, administered as 2.5-gram vials consequently. Clinical evidence from RE-VERSE AD trial demonstrated rapid and effective reversal of dabigatran's anticoagulant effect. Since dabigatran has relatively low protein binding, hemodialysis can also be considered if additional drug removal is required. On the right is Andexanet Alfa, marketed as Andexxa. It is indicated for factor X inhibitors, including rivaroxaban and apixaban. The dose depends on the specific NOAC, its dose, and the timing of the last administration. Evidence from the Annexa 4 trial showed that a marked reduction in anti-factor XA activity after the treatment. However, because Andexanet alpha may increase the risk of the thrombosis and rebound the anticoagulation, patients should be monitored carefully after the administration. So, when using the Idarucizumab only for Dabigatran and Andexanet Alfa for factor X inhibitors, selecting the correct antidote is essential for safe and effective emergency treatment. Sometimes the specific antidote is not available, and in those situations, we rely on non-specific reversal strategies. However, these therapies should be used in a clear order of priority. Tier 1 is 4-factor prothrombin complex concentrate or 4-FPCC. It is a preferred option, especially for factor X inhibitor related by bleeding, and is given at 25 to 50 units per kilogram IV. It works by replacing the vitamin K dependent clotting factors and helps restore the coagulation rapidly. If 4-FPCC is unavailable, Tier 2 is activated PC, also known as FEIBA. It is administered at 50 to 80 units per kilogram. Although effective, it carries a higher risk of thrombosis, so it should be considered a second line option. Tier 3 is a recombinant factor 7A or RF7A. This is reserved as a last resort because of very high arterial thrombotic risk and relatively short duration of action. Also remember the important adjuncts shown on the right. Hemodialysis is useful only for dabigatran. Activated charcoal is effective only if that was ingested within 2 to 3 hours, and fresh frozen plasma is not recommended because it does not reverse NOACs effectively and increases the risk of fluid overload. So the key message is to use non-specific reversal therapies only when the specific antidotes are unavailable, and always follow the recommended treatment hierarchy for the safest patient outcome. One of the most important principles in emergency medicine is treat first, verify later. In life threatening bleeding caused by the NOACs, you should never delay the antidote administration while waiting for the specialized laboratory results. The highest priority is intracranial hemorrhage because the hematoma can expand rapidly within the first few hours, leading to permanent neurological damage or death. The second red flag is hemodynamically unstable GIT bleeding, especially when the systolic blood pressure remains below 90 mmHg despite blood transfusion. These patients require immediate reversal of anticoagulation. The third situation includes occult or hidden bleeding, such as the pericardial tamponade or retroperitoneal hematoma, particularly in patients with unexplained hypotension or shock. Finally, if the patient requires urgent life saving surgery, rapid reversal of anticoagulation is essential to minimize the surgical bleeding and improve the outcomes. For dabigatran, Idarucizumab is approved for emergency perioperative reversal. Always remember the emergency sequence shown at the bottom of the slide. Call the blood bank, secure the airway, control the blood pressure, and administer the appropriate antidote without delay. In critical bleeding, every minute counts and early intervention saves life. Reversing the anticoagulation can stop life-threatening bleeding, but it also shifts the patient towards an increased risk of thrombosis. This balance is often described as pendulum of thrombosis, where the clinicians must carefully weigh bleeding against the clot formation. One important complication is the thrombotic rebound. Since Andexanet alpha has a short half-life of about 1 hour, its effect may wear off before the anticoagulant has completely cleared, allowing the bleeding or hematoma expansion to reoccur. Another concern is TFPI inhibition. Andexanet alpha not only binds the factor XA inhibitors but also inhibits the tissue factor pathway inhibitor TFPI, creating a temporary prothrombotic state. In the Annexa 4 trial, thrombotic events occurred in appropriately 10% of the patients. Although Idarucizumab is highly specific for Dabigatran, thrombotic events can still occur because reversing the anticoagulation reveals the patient's underlying risk, such as atrial fibrillation or previous thromboembolic disease. Similarly, overdosing factor the 4 factor PCC may lead to excessive clot formation and, in severe cases, disseminated intravascular coagulation or DIC. Finally, remember that anticoagulation should not be withheld indefinitely. Once the bleeding is controlled and the patient is stable, anticoagulant therapy is generally restarted within 24 to 72 hours, depending on the clinical situation, to reduce the risk of the stroke and other thromboembolic complications. So, successful reversal is not the end of the treatment, it is the beginning of carefully restoring the balance between the bleeding and the thrombosis. Let's test your knowledge with a high yield clinical case similar to what you may have encountered in NEET PG, USMLE, or clinical practice. A 74-year-old man with atrial fibrillation is taking dabigatran and presents with acute left-sided hemiplegia. A CT scan confirms the intracranial hemorrhage. His laboratory results show at APTT of 90 seconds while the INR remains normal at 1.1. So the question is, which is a specific reversal agent of choice? So the correct option is Idarucizumab, option B. Here's the reasoning. Because dabigatran is a direct thrombin inhibitor and its anticoagulant effect typically causes a prolonged APTT while the INR remains normal. Therefore, a prolonged APTT with a normal INR strongly suggests that dabigatran associated bleeding. Idarucizumab is a specific antidote for dabigatran and rapidly reverses its anticoagulant effect. Andexanet Alfa is used only for factor X inhibitors. Protamine reverses the heparin, and 4-factor PCC is considered only when a specific antidote is unavailable. So, a simple exam tip to remember is high APTT plus normal INR points towards dabigatran. So, think Idarucizumab immediately. Let's look at another higher clinical scenario that highlights an important complication of Andexanet alpha. A patient taking apixaban develops a severe GI bleeding and receives Andexanet alpha. Immediately after treatment, the anti-factor XA levels fall from 220 to just 12 nanograms per milliliter, showing successful reversal of the anticoagulation. However, 4 hours later, the patient develops new bleeding and the anti-XA level rises against 185 nanograms per milliliter. What is the most likely explanation? So the correct answer is rebound anticoagulation, which causes the short half-life of Andexanet alpha, which is approximately to 1 hour. As the antidote is rapidly cleared from the circulation, any remaining factor XA inhibitor can once again exert its anticoagulant effect, leading to the recurrent bleeding. So the graph on the right clearly demonstrates this phenomenon. Anti-XA activity decreases dramatically during the infusion but rises again after the antidote effect wears off. This is why patients treated with Andexanet alpha require close monitoring, especially during the first 2 to 4 hours after the reversal. In contrast, Idarucizumab provides a longer duration of action with a much lower risk of rebound, while 4-factor PCC has an immediate duration of approximately 6 to 8 hours. So, after giving Andexanet alpha, don't assume the problem is over. Continue close monitoring because the rebound anticoagulation can occur once the antidote effect fades. Let's conclude with some practical guidance for the managing of NOAC related bleeding in India. First, consider drug availability. Idarucizumab is available in India, but it is expensive, typically costing around 1.5 to 2.5 lakh. And Andexanet alpha is still rarely available in most of the hospitals. Therefore, factor X inhibitor related bleeding, 4-factor prothrombin complex concentrate or 4-FPCC is often the most practical alternative. Second, be aware of the laboratory limitations. Specialized tests such as dilute thrombin time or DTT are not available in many centers. In this situation, normalization of the APTT used as a practical surrogate to assess dabigatran reversal. So the most important clinical message is highlighted in red. Never delay the treatment while waiting for laboratory assay results. In patients with life threatening bleeding, administer the appropriate reversal therapy immediately based on the clinical history and the anticoagulant being used. Finally, remember your responsibility for pharmacovigilance. All significant ADRs, adverse drug reactions, and reversal related events should be reported to Pharmacovigilance Program of India or PVPI under SEDISCO to improve drug safety and patient care across the country. So, in India, use the best available evidence, the resources you have, and never delay life saving treatment while waiting for perfect laboratory confirmation. As we conclude, remember the three golden rules of emergency NOAC reversal. First, the right drug. Second, the right dose. And third, the right timing. First, the right drug. I'd always identify the anticoagulant before choosing the reversal agent. Idarucizumab is the specific antidote for Dabigatran, while Andexanet Alfa, or when unavailable, 4-factor PCC is used for factor X inhibitors such as rivaroxaban and apixaban. Second, the right dose. Administer the full recommended dose without delay. Dabigatran reversal requires 5 grams of idarucizumab, while 4-factor PCC should always be given according to the patient's body weight and current clinical guidelines. Third, the right timing. In life-threatening bleeding, every minute matters. Never postpone the treatment while waiting for specialized laboratory assays. Treat the bleeding immediately first and confirm with laboratory tests later. If you found this lesson helpful, please like, share, and subscribe our channel. Feel free to leave your questions in the comments below. Thank you so much for watching this presentation. I hope this session has helped you better understand the NOAC reversal strategies, specific antidotes, emergency management, and their practical clinical applications. If you found this video helpful, please like, share, and subscribe for more evidence-based medical lectures designed for the MBBS students, PharmD students, NEET PG, USMLE, FMGE aspirants, and healthcare professionals. If you have any questions, case discussions, or topic suggestions, feel free to leave them in the comments below. Thank you once again. Stay safe, keep learning, and I'll see you in the next lecture.